Welcome to the MRCPology channel for a quick review and understanding of the topic. Imagine a patient who presents with recurrent wheeze, cough, chest tightness, and breathlessness, especially at night or early in the morning. The key clinical question is not just, does this patient wheeze? The real question is, are these symptoms variable, trigger-related, and supported by objective evidence of variable airflow obstruction? Asthma is a chronic inflammatory airway disease. It causes variable airflow obstruction, bronchial hyperresponsiveness, and reversible bronchoconstriction. In simple terms, the airways are inflamed, easily irritated, and able to narrow episodically, which explains why patients can be very symptomatic during an attack, but have a normal examination between episodes. To understand asthma, think in three linked boxes: inflammation, bronchoconstriction, and long-term airway change. First, inflammation. A trigger such as an allergen, viral infection, exercise, cold air, smoke, or occupational exposure activates the airway epithelium. This drives type 2 inflammation involving interleukin 4, interleukin 5, interleukin 13, IgE, eosinophils, and mast cells. These inflammatory pathways cause airway oedema, mucus hypersecretion, and smooth muscle contraction. That mechanism explains the symptoms. Wheeze happens because narrowed airways create turbulent airflow. Cough comes from airway irritation and mucus. Chest tightness reflects bronchoconstriction. Breathlessness develops because airflow is limited, especially during expiration. The second box is bronchoconstriction and mucus plugging. Narrow airways plus mucus lead to expiratory flow limitation. Air gets in, but it struggles to get out. This causes air trapping and hyperinflation, which increases the work of breathing. In severe attacks, airflow may become so poor that wheeze disappears, giving a silent chest. That is dangerous because it may mean the patient is too obstructed or too exhausted to move air. Hypoxia, exhaustion, and hypercapnia are late and serious features. The third box is airway remodeling. Chronic inflammation can lead to goblet cell hyperplasia, smooth muscle hypertrophy, and structural airway change. Over time, obstruction may become less reversible, and asthma control can worsen. Clinically, asthma classically causes variable wheeze, cough, breathlessness, and chest tightness. Symptoms are often worse at night or in the early morning because airway caliber and inflammatory tone worsen overnight. MRCP trap, a normal chest examination between attacks, does not exclude asthma. Common triggers include viral upper respiratory tract infection, allergens, smoke, vaping, cold air, exercise, NSAIDs, beta blockers, and occupational exposures. A personal or family history of atopy supports the diagnosis, but it is not enough on its own. Diagnosis requires compatible variable respiratory symptoms plus objective evidence. Do not label confirmed asthma on symptoms alone. In adults, spirometry showing an FEV1 to FVC ratio less than 70% supports obstruction. Evidence of type 2 airway inflammation may come from a raised FeNO or raised blood eosinophils. Bronchodilator reversibility is shown by an improvement in FEV1 of at least 12% and at least 200 milliliters. Peak expiratory flow variability or bronchial challenge testing can also demonstrate variable airflow obstruction or bronchial hyperresponsiveness. Now let us move to long-term treatment. Acute exacerbation management is separate. For chronic asthma management in patients aged 12 and over, the key principle is treat the inflammation, not just the bronchospasm. This is why SABA alone is no longer the preferred approach. A short-acting beta agonist may relax airway smooth muscle, but it does not treat the underlying airway inflammation. The inflammation is the disease driver. For newly diagnosed mild asthma, the starting approach is AIR therapy, meaning anti-inflammatory reliever therapy. This uses low-dose inhaled corticosteroid with formoterol as needed. Formoterol is important because it is a fast-acting LABA, so it gives rapid bronchodilation. The inhaled corticosteroid treats inflammation at the same time, so every time the patient reaches for symptom relief, they also receive anti-inflammatory treatment. If the patient is highly symptomatic at diagnosis or has had a severe exacerbation, start low-dose MART instead. MART means maintenance and reliever therapy. It uses inhaled corticosteroid with formoterol, both as regular maintenance and as the reliever. Low-dose MART usually means 1 puff twice daily, plus additional puffs when needed. If asthma remains uncontrolled on as-needed air, step up to low-dose MART. If still uncontrolled on low-dose MART, step up to moderate-dose MART, usually 2 puffs twice daily, plus as-needed reliever use. If asthma remains uncontrolled despite moderate dose MART, first check adherence and inhaler technique. This is a major MRCP trap. Before escalating treatment, ask whether the patient is actually receiving the medicine correctly and consistently. If adherence is good, check FeNO and blood eosinophils. If these are raised, that suggests ongoing type 2 airway inflammation, and the patient should be referred to an asthma specialist. If FeNO and eosinophils are not raised, consider an add-on trial with either an LTRA or a LAMA for 8 to 12 weeks. LTRA means leukotriene receptor antagonist. In asthma, mast cells and eosinophils release leukotrienes, which contribute to bronchoconstriction, airway oedema, and mucus production. An LTRA blocks leukotriene receptors, reducing bronchospasm, mucus, and airway inflammation. LAMA means long-acting muscarinic antagonist. Normally, parasympathetic vagal stimulation releases acetylcholine, which acts on M3 receptors in airway smooth muscle. This causes bronchoconstriction and mucus secretion. A LAMA blocks M3-mediated cholinergic airway tightening, producing bronchodilation. If asthma remains uncontrolled after one add-on trial, try the alternative add-on, meaning the LTRA or LAMA that has not yet been used. If control is still poor despite moderate dose MART and trials of LTRA or LAMA, refer to specialist asthma care. If you remember one thing, remember this. Asthma is not simply episodic bronchospasm. It is chronic airway inflammation causing variable airflow obstruction. That is why modern management pairs symptom relief with anti-inflammatory treatment. Quick recall. A 24-year-old has episodic wheeze and cough, worse in the early morning, with a normal chest examination in clinic. Can asthma be excluded because the examination is normal? The answer is no. Asthma is variable, and examination may be normal between episodes. The diagnosis needs compatible symptoms, plus objective evidence such as spirometry reversibility, FeNO, eosinophils, peak flow variability, or bronchial challenge. A patient with newly diagnosed mild asthma asks for a salbutamol inhaler only because symptoms are intermittent. What is the key management trap? The answer is prescribing SABA alone. The modern principle is to treat airway inflammation as well as bronchospasm, so low-dose ICS formoterol anti-inflammatory reliever therapy is preferred for mild asthma. Do subscribe to the channel for further videos.